Headaches. Either we've suffered from a headache at some point in our lives, or we know somebody who has. And even if they haven't, everybody generally suffers from at least one headache in their lifetime. So this is just a whistle-stop tour of the different types of headaches that are, and a very brief bit of kind of key features for each type of headache that might be. So categorically, before we begin, there are two types of headaches, and they're what we refer to as primary headaches and secondary headaches. Now, primary headaches are the headaches that we generally see in the vast majority of the population. Secondary headaches are the ones that leave us room for concern and are significantly more sinister and therefore require immediate and urgent medical care and attention. So let's begin with the primary headaches. The first and foremost that I'm going to actually throw in here is your tension type headache. Typically, the patient is stressed. This can affect any group, any age, any gender. And the tension, whether it's personal, work-related, financial, family, studies, literally anything, any form of stress, anything that might be on your mind, you can't take it off. And that usually leaves you with this headache, what's known as a tension type headache, and that's usually a band-like sensation in and around the head over here. Treatment here usually is to try and take your mind off things, to try and address the root cause, which inevitably is the actual headache itself, the stress itself rather. And some of the ways to manage stress really is to try and go out, socialize, go for a walk, anything that might distract you. And so that's kind of the resolution. Should that fail, then what we usually suggest is let's just take some simple analgesia. And simple analgesia includes your paracetamol. Failing that, then we up it to maybe ibuprofen if it's safe to do so. And then after that, we can introduce a little bit of codeine in there. So the likes of Panadol, which contains an element of caffeine. This synergizes the absorption of some of the other products. And then some also contain the codeine in there as well, of a slightly higher strength than the one that you can buy otherwise. So that's your tension type headaches. Next in line comes your migraines. Migraines with aura, migraines without aura. Auras are the prodroma, that is, flashing lights, flickering lights, flashing stars, lines, horizontal or vertical, any form of kind of prodroma. And prodroma usually is a result of you get vasospasm. Vasospasm means that you get every artery has arterial vasospasm, to be specific. All blood vessels, arteries and veins contain a muscular element. If you get spasm of the muscular aspect of that in blood vessels, we refer to that as vasospasm. Now, vasospasm of the arteries due to prolonged exposure to the actual stimulus. So whatever the stimulus is here, and with migraines, there are various stimuli: coffee, chocolate, light, amongst ice cream, amongst some of the more common ones. So you get vasospasm of the arteries due to prolonged exposure to the actual stimulus. That then leads to occlusion of the artery to some degree, or rather narrowing of the artery, or more so the actual inner aspect, reducing the blood flow to the area, to the part of the brain or the area it supplies. And that restricted blood flow leads to an element of ischemia. Ischemia, if you remember, is actually reversible changes due to the actual blood flow. It's a respiratory, an oxygen deficit. The respiratory demand is not being met, although this is reversible and temporary. So that deficit is what then leads to the actual prodroma. That is that ischemic ischemia that leads to the prodroma. So that's migraine with and without auras. Now, with migraines, what we usually do is we advise triptans. So the most common one is sumatriptan. You can actually buy sumatriptan over the counter as well in some pharmacies. It is a licensed sale for migraine, so Migraleave can as well. But then, like I say, your sumatriptan. Failing sumatriptan, what you can then do is go on and get what we call ergotomies. These again are prescribed by the GPs. Now, as a prophylactic, as a preventative measure, what we do is we use beta blockers. The one that we usually use is propanolol. That comes as 10, 20, 40 milligrams. It goes up in 10. So 10 and 40 milligrams is the one that's usually prescribed. And this is to actually prevent migraines and to manage them in the long term, so prophylactic treatment. Okay, what I'm going to mention next is dehydration headache. Now, dehydration is extremely common in the context of a hangover. The alcohol, the night before, otherwise a headache, a dehydration headache. And with a hangover particularly, what happens, and this comes from Guyton and Hall medical physiology, what happens is the dehydration causes a reduction in the actual CSF, the cerebrospinal fluid, that bathes the brain and the spinal cord. That reduction, it only needs to be a very, very small amount to actually cause the symptoms. That reduction actually causes the brain to, where it's suspended in plenty of fluid, the reduction causes the brain to sink a little to some degree, and that very few degrees, and I mean literally 1 degree is sufficient to actually cause a pulling, a tethering of the meninges. Now the meninges are there are three protective layers, three protective membranes around the brain and spinal cord, our central nervous system, what we call the dura, the arachnoid, and the pia mater. That reduction in the fluid means the suspension is reduced, the brain kind of sinks somewhat, literally by a few degrees, and that is sufficient to cause a tethering, a pulling on the edge of meninges, and it is that what causes this dehydration headache. So that's how that one works. Okay. Next in line, I'm going to mention is, so we've done tension into migraines with that, or as we do dehydration. I think we can move on to cluster headaches. So cluster headaches typically affects males 20 to 40 years of age. As the name suggests, they come in clusters, so clusters of headaches. And again, we can have predisposing factors here, similar to that we got with migraines. However, the key features here are male 20 to 40 years of age, and they come as groups of headaches. And the groups of headaches that occur, the clusters that occur, can be sporadic, and therefore the time variation between them is not really fixed. The key feature with these is some neurological involvement. So you can get watering of the eyes, you can get facial pain, neuropathic pain that's kind of nerve-like in origin, eye pain, a runny nose. So these are typical features of cluster headaches. Now with cluster headaches, what we do in terms of treatment is we will use, as a prophylaxis, we'll use a calcium channel blocker called verapamil. And this aids the management of symptoms. Should verapamil fail, then only then we consider using lithium, or rather we use prednisolone. Now prednisolone is a steroid, of course in a low dose is what we'd use, and of course long-term steroid use has its implications, its side effects. And of course lithium. Now lithium is an interesting drug, usually used primarily in the treatment of bipolar disorder, in mental health issues in psychiatry. Lithium is a tricky one because it has a lot of drug interactions, and also has a very narrow therapeutic index, which essentially means that should you move outside that window, it's a very, very small margin of error, and if it goes too high or too low, then it has its implications. So lithium toxicity and otherwise. If it's too low, then of course it's ineffective, as well as other side effects. But primarily with cluster headaches, what we do is we get 100% oxygen, and that's what usually happens. Now, interesting it is to know that cluster headaches with their neurological component, the use of 100% oxygen implies again that there's some element of ischemia here, probably due to the vasospasm. So this is likened very closely to migraines with auras, or without auras, but certainly with an element in neurological involvement. Okay, so that was your primary headaches. Now, the next one I'm going to mention, personally, I like to put these in a grey area. They're not primary, in my point of view, in their entirety, but on the same token, they're not secondary either. But they are, so they're not emergency immediate care in the context of secondary headaches, which you'll learn in a few moments, but these are still of significant value because you cannot manage them in primary care on their own, and they require specialist involvement, and that's why I personally classify them as, whereas the primary headaches you can manage in primary care, so these require involvement to the secondary care, but are generally managed for the most part of them in primary care. So let's move on. Trigeminal neuralgia. Trigeminal nerve. So in the brain we've got, or around the face and the head and the face, we've got 12 nerves, 12 sets of pairs of nerves known as the cranial nerves, 1 to 12, right and left. The fifth cranial nerve is what we call the trigeminal nerve, and this has exits over here and has 3 branches. The 3 branches, it has V1, V2, and V3, otherwise known as the ophthalmic, the mandibular, the maxillary, and the mandibular branch. Now, the maxillary and the mandibular branch are most commonly affected, and what happens here is the nerve is irritated, and this creates a severe lancinating pain, a searing pain along this region here. Now, as a mere fact, pain in and around the face is, and I remember reading this, about 20 times, it's felt 20 times greater than anywhere else on the body. So it's horrific. Now, and the other thing I might mention, what's worth mentioning here, is nerve pain is probably the worst type of pain that we can experience. So you've got the worst type of pain that we can typically experience, i.e. nerve pain, and we've got that in the face, and that's usually 20 times worse. That's telling. That's telling. Another fact that I do recall on the back of neuralgia, TGN, some time ago, so this might be an outdated fact, however, it's important to note that in America, TGN was at some point classified as being the 3rd most common cause of suicide, would you believe? That's telling. That's very, very, very telling. Anyhow, getting back to the point. So, trigeminal neuralgia, horrible, horrible pains around this region, neuropathic in origin. How do we manage it? A very difficult one, really. Carbamazepines is what we use, and if they work, fantastic. It's a hit and miss. Failing the pharmacological intervention of carbamazepines, what we then consider surgery, and again, surgery it's if it works again, great. If not, it's a challenge. It's very much a matter of trying to gain a symptom relief with TGN. Next in line is your GCA, so giant cell arteritis, also known as temporal arteritis. Why? Because it's the temporal artery, which is literally on your temple over here. That's most commonly affected. Now, GCA, giant cell arteritis, implies inflammation of a giant artery, the larger artery. So the temporal artery, like I say, sitting over here. And now, GCA or TA is usually occurs in older females, 50, 60 years of age, and by that I don't mean older, I mean females are 50 in the 5th or 6th decade of life. Why? It's just naturally the case. Now, what's interesting to note here is that patients also usually have, or otherwise there's a strong link with a condition called PMR, polymyalgia rheumatica. Now, polymyalgia rheumatica occurs in patients 50 to 60-year-old females. They come in, they say, I've got a headache. It's usually one-sided. That's with the GCA. Now, PMR has bilateral shoulder pain, which has rheumatological origin, that is rheumatological. So the point I'm making is 15 to 30% of patients with PMR will suffer from GCA. So there's a good strong link here. So if you've got a patient who's got PMR diagnosed and they're complaining of headaches at that age category, etc., then don't dismiss this concept. The important thing with this is it can cause irreversible blindness because of the optic neuritis that occurs. So what they might also suggest is I've got a history of PMR, or otherwise I've got scalp tenderness when I'm combing my hair. It's very tender. It's an immediate referral to emergency care. We need to give them high dose 40 to 60 milligrams of prednisolone. to try and bring down the inflammation. Gold standard is to actually do a biopsy of the temporal artery, and with the bloods we're measuring their ESR levels predominantly, which can be as many as 3 times higher than they should be. Of course, the CRP will also be raised. So the point I'm making here is these two, the GCA and the TGN, are, like I say, in that grey area. Let's move swiftly onto our secondary headaches. I'm going to keep it simple. Meningitis, I'm going to put number 1 here in terms of relatively common. 2 types of meningitis, viral and bacterial. The bacterial is the more horrible one. Unfortunately, the viral is relatively common and self-limiting. Meningitis headache, what will they say? Well, I've got some neck stiffness as well, and bringing the chin to the chest is difficult. It will actually elicit pain. This is actually component of a couple of the tests that we do for meningitis, the Brusicity sign, amongst others. So meningitis, there'll also be photophobia, systemically unwell, fever, temperature, lethargy, anorexia. So all those symptoms in context with photophobia, so dislike to light, alongside neck stiffness, and you're really immediately thinking meningitis. So then, of course, we need to do a lumbar puncture. We analyze the CSF, the cerebrospinal fluid, and we look for the markers that we do. We analyze that, looking at the glucose levels in there, the protein levels in the CRP rather, and the white cell count, amongst others. Next in line is subarachnoid hemorrhage. So subarachnoid, now notice I mentioned earlier 3 meninges, the 3 layers that surround the actual CNS, the central nervous system, the brain and the spinal cord. The dural mater, the arachnoid mater, and the pia mater. Subarachnoid, sub means under, arachnoid is one of the layers, the middle layer rather. A bleed, hemorrhage refers to a bleed. A bleed that leaks the blood in this space between the dural mater and the arachnoid mater. And the thing here is it's usually young females who have had some level of trauma to the head. The headache occurs, it's a low, grumbling, low-lying headache in the background that has no alleviating factors. Simple analgesia doesn't alleviate it. As it goes on, even more potent analgesia doesn't help. No relieving factors, no position of ease, the headache is constant and it's worsening. These are all signs of significance. These are signs to suggest actually we need to really take a serious approach on this. You'll recognize all secondary headaches that I'm going to mention from here on. And we do a CT scan, and the CT scan we do over an MR. Why? Because it's quicker, it's more cost effective, it's 20 minutes and you can have one range, it's cost effective, and there are less contraindications. With MR scan, we really got to screen the patient, and in the context of emergency settings, sometimes the difficulty of accessibility and the actual contraindications such as metalwork in the body, these are absolute no-goes amongst the cost side, whoever cares about that. Well, the NHS, as we know that, and management there. However, the point I'm making here is it's important factors. So CT is availability. So we do a CT here. Subarachnoid hemorrhage, then we'll move on to subdural hematoma. Subdural hematoma usually occurs in older patients, again, who have had a fall, not necessarily even trauma, fall. Why? Because as we age, the elasticity in blood vessels actually reduces somewhat. We also become somewhat more dehydrated. Now, what happens as a result of all of this is the CSF that the brain is suspended in is somewhat reduced, not enough to cause headaches, but just slightly reduced. And again, the fragility of the actual blood vessels means any trauma, any fall is sufficient to actually cause a shuddering inside, and that might actually just break the blood vessel, and that will cause a hemorrhage. My apologies, I just realized I said subdural hemorrhage, it's subdural hematoma, which is a slow bleed. And the difference between the hematoma and the subarachnoid hemorrhage that I'm mentioning here is the fact that the headache that comes on is sudden. Patient might describe it as the worst ever headache, a thunderclap headache, or it felt like someone really gave me a real bash on the back of my head with a baseball bat or something like that, and that's what they experience. And this is a real telltale sign. So why? Because that blood vessel just ruptured. There's a massive bleed in the blood in the actual cavity, intracranial cavity. So this is massive of a concern. This immediately warrants a CT also. And of course, over time, this is fatal. as is the subdural hematoma, of course, albeit a slow bleed, and so it can go a little unnoticed initially. The last one I'm going to mention is extradural hematoma. So again, hematoma meaning a slower bleed. Extradural meaning it's outside the dura mater, and what we've got here is it's usually boxers or younger males. Again, trauma-induced, and again, you've just got to appreciate that the headache, in a similar fashion to the subdural hematoma, extradural hematoma is in a similar fashion slow. It's a low grumbling, constant headache in the background. No alleviating factors, simple analgesia, and then potent analgesia doesn't help. The headache is slowly getting worse. Now, with all three of these, you may also start to experience elements of neurological deficit, not deficit in the context of stroke, but neurological symptoms such as nausea, vomiting, anorexia, these kind of symptoms. In all of these cases, the top priority is to actually, what we want to do is we want to reduce the intracranial pressure. Now, how can we identify some of this? If you do get a patient experiencing this, one of the key telltale signs is that if the patient lays flat, the headache is worsened. This is an indicator of raised intracranial pressure, be it from a bleed or from a space-occupied lesion. What you'll also possibly do is, if you've got the facilities and the skill set, then fundoscopy, a quick fundoscopic examination will reveal papilledema, swelling of the optic disc. Whiz them off to A&E. The top priority here is to reduce the ICP. We do not do a lumbar puncture here. What we do is we consider borehole surgery, just literally let the bleed come out, and we just need to let the actual pressure reduce. And we also consider the use of mannitol, which works on the nephron in the kidney, and that again helps to reduce the pressure, the intracranial pressure. That was a whistle-stop tour, as I might suggest, a quick overview of the most common types of headaches that we might see. There are other types, but they are less common, and I hope that was helpful. Feel free to like, comment, and share the videos as ever, and I hope you enjoyed that. Thank you very much.